having last presentation of today, you must be tired, so I'll try that not to bore you with the topic. This is a very interesting topic and the most common one, especially in Pakistan. And you must have a lot of experience with tuberculosis, and so we are going to share our experiences with each other. Well, this is father of the nation. The reason I have pasted this photograph here is that the TB is our enemy, and the father of the nation had TB in his terminal days, and he died because of that. And in addition, this disease doesn't differentiate between poor and rich, though it is labeled as involving those who are socio-economic compromised. Why this topic is important for a family practitioner? The number one reason is that the family physicians are the first contact person, and the patients usually come to you first, and you have the best opportunity to detect the case and to identify the case, to manage the case and follow. You can also educate the patient and about the treatment, side effects, follow-up, and promptly refer the complicated cases to specialists. And the majority of the patients will be treated by you. This topic is very important for MRCGP exam because the reason they have separated MRCGP UK and MRCGP South Asia is that in South Asia the prevalence of infectious disease is very high. So this topic is frequently asked on examination. And MCQs will be containing X-ray films, case scenarios, and in OSCE you might end up examining or evaluating a patient to whom you have to show your communication skill and explain about his TB. So the level of competency which is expected from you is that you should be able to formulate a differential diagnosis when the patient with TB comes to you, and diagnose it by clinically and advising laboratory investigations, and then treat accordingly. And the most important thing is that the complicated cases should be referred. At 3 levels, you should be competent enough: individual, health system, and national level. At an individual level, you should be able to diagnose and treat cases, and at health system level, you should be contributing to reduce morbidity and mortality. And at national level, this will automatically preserve the productive manpower and reduce the cost of treatment by prevention and early detection. Objectives of today's topic: to give an overview of the spectrum of tuberculosis, and by the end of the session you should be able to detect cases of tuberculosis and identify those cases which should be managed in primary care and those cases which needs referral. This is a graveyard, and you can well read that some of the gravestones are saying killed by tuberculosis. So the tuberculosis was epidemic in 18th century in Europe, and at that time the incidence of tuberculosis was low in our region. And this is a cartoon showing a patient with tuberculosis deathbed, and this is the angel of death just waiting for the time. This is a picture of TB sanatorium, and in those times, because the first anti-TB drug isoniazid came in 1944. So before that, usually they put the patient in sanatorium assuming that the fresh air might be able to cure the TB. And there were other modalities like surgeries, putting a spontaneous pneumothorax, but those were not very useful. And this is another picture showing TB sanatorium in which patients with TB are sitting and lying. Let's discuss a few points about epidemiology. Why is it important? TB is a curable disease. Someone was saying that it's like AIDS. It's like AIDS of 18th or 19th century. But fortunately, it is a curable disease. And imagine that every day, 5,000 people are killed by TB. and imagine that every second in the world, one person is being infected with tubercle bacillus. And almost 1/3 of the world's population is infected with TB bacillus. And now MDR TB is a major threat. Regarding pathogenesis, it's a disease which is contagious and spreads by airborne and droplet nuclei. The difference between airborne and droplet is that the airborne particles, they are very, very small and they are taken away by the currents. So if someone with TB is coughing in this room and you open the door, so those airborne droplets or airborne nuclei will be carried through the door to the patient who is susceptible or person who is susceptible. 10% of the patients who are infected will develop TB, active TB, at some point in their lifetime. Infection and TB disease are different. If someone has inhaled a tubercle bacillus and it's not causing an active disease, but it is contained by the body's immune system, that patient is called infected with TB. And if the immune system is low and that contained focus, the tubercle bacillus spreads to the other body parts or form an active disease, that is called active tuberculous patient. HIV is the strongest factor, and in Pakistan it's really growing. In the past 2 weeks I have seen 4 or 5 HIV patients, and similarly my other ID colleagues are seeing a lot of HIV patients. There are certain medical conditions, especially which lower the immune system, that increase the risk of TB. And these are the conditions you all know, especially immuno-compromised conditions, substance abuse, end organ failures like uremia and stage renal disease, recent infection, underlying lung pathology, especially silicosis, patients who work in the mines. Silicosis impairs the macrophage function and thus predisposes to TB. TB is a disease which can affect every organ of the body. It can involve the brain, skin, lungs, GI system, genitourinary system, and it can disseminate involving multiple organs, or sometimes can invade the blood vessels and spread hematogenously. How we are going to evaluate a patient of TB? The first thing and the most important thing is medical history, and then physical exam and investigations, which we are going to discuss in a little bit detail. TB antigen testing, just like microdot test we do here, there are no good studies which show that this is useful. Basically, PCR is coming as a useful, good, rapid test which can detect TB cases. But basically, in a primary care setting, you are concerned with PPD or Mantoux test, chest radiograph, sputum smear culture, and the biopsy histopathologic specimens, and the other labs which are non-specific but can suggest. What are the symptoms of TB? Pulmonary TB is more common in adults, and usually the cardinal symptoms are productive cough for more than 3 weeks, chest pain, hemoptysis, shortness of breath. But in addition to it, there are some non-specific symptoms like fever, chills, night sweats, loss of appetite, anorexia, weight loss, and easy fatigability. So you have to put all these things together and see, because these non-specific symptoms, they can occur in other infectious and non-infectious diseases. In medical history, when you are evaluating a patient, the most important thing is does the symptoms diagnose to a specific organ? Like if a patient is coughing, hemoptysis, shortness of breath, this is pointing that this patient might be having pulmonary TB. But if a patient does not have pulmonary TB, it can affect other organs. So if a patient is having headache, weakness, confusion, he might be having tuberculous meningitis. Or if a patient is having abdominal pain, diarrhea, weight loss, he might be having gastrointestinal TB. So you have to take a good review of system to find out which system is being involved. History of TB exposure is important. Does this patient has anybody in his home or acquaintances who has active case of TB? Past TB treatment. If a patient has TB in the past, and even if it has been treated, there is a 5 to 10% chance that it may relapse. Demographic risk factors and medical conditions we just discussed, and patients' poor socioeconomic condition, crowdy home conditions, and poor sanitation, malnutrition, All these factors, they predispose to TB. After medical evaluation, the physical exam is important, and this is a picture showing a nurse examining the patient. And in pulmonary TB, chest exam is very important. But if you don't find a focus, then complete examination is very important. Sometimes a nodule on the epidermis is the only sign you can detect for disseminated TB. And sometimes a subtle finding, the patient is confused, is the first sign which you can detect this patient might be having CNS involvement. So if the symptoms are not pointing, or the signs are not pointing towards a system, then subtle findings can point you towards correct diagnosis. Height and weight are important, like non-specific symptoms. Patient is losing weight, patient is having low-grade temperature, evening rise. So all these things can suggest this patient might be suffering, especially in Pakistan, which is highly endemic area. Coming to the testing for TB, Mantoux PPD, this is an old test in which purified protein derivatives of tubercle bacillus, they are injected intradermally. 0.1 ml or 5 tuberculin units, standardized units, they are injected intracutaneously, and then it is read after 48 to 72 hours. Now what do we read when we read the skin test? We don't look at the blister, we don't look at the erythema. The most important thing in reading a PPD test is that how big is the induration. So for induration you have to feel it. The other good way is that with the ballpoint, you just push the ballpoint and slide it until it stops by induration. And opposite side you do the same, and then measure that area. And usually the PPD is measured 5 mm or more, 10 mm or more, or 15 mm or more. This is a positive PP test, and you can see that the blister formation has occurred. But erythema and blister formation, this is not what we are measuring. We are measuring erythema, and we are measuring induration. How do we interpret? If induration is 5 mm or more and patient fits into this criteria, then you can say that this PPD is positive. Either patient is an HIV or other immuno-compromised condition. Recent contacts of an active TB case. Patient comes to you who has a child 5 years old, and the patient has active TB, and the child's PPD is 5 mm. This is positive. And healed tuberculosis. If patient has induration of 10 mm or more, then you have to look whether he has other risk factors, any close contacts, any previous history of TB, any occupation or medical condition that predisposes him to have TB. Is he elderly? Is he child less than 4 years of age? If he has those risk factors and the induration is 10 mm, then it is considered positive. So generally for our people or our community, usually 10 mm or more should be considered positive. Induration of 15 mm or more, usually for those persons who don't fit into either of these two criteria. The other question is, what about BCG vaccination? BCG vaccination can cause falsely positive PPD, but usually the reaction wanes in 4 or 5 years. So it is said that the PPD interpretation should be done irrespective of the BCG vaccination. This is a chart showing what are the false positive and false negative, which can cause false positive, false negative PPD. Okay, what if Mantoux test is negative? Does that rule out that the patient does not have TB? No. 10 to 25% of the patients with active disease have negative PPD. So PPD is an epidemiological tool. It only tells that this patient is infected, it has been exposed. But for active TB, you have to look other things in the history and physical exam. Chest radiographs, very important. Abnormalities usually are seen in apical posterior segments of upper lobe or superior segments of the lower lobe, and may have unusual appearance in HIV positive person or any patient who has immunocompromised condition. This is an X-ray showing typical right upper lobe cavitary, fibrotic and consolidated lesion. typical for tuberculosis. This is another chest X-ray showing right upper lobe consolidation and fibrocystic changes. Okay, what does this chest X-ray show? Miliary, right? You can see, if you can concentrate, fine shadowing, fine reticular shadowing, just like tiny dots. And if you look close, you can see that there are fine dots distributed all over the chest. And this is more prominent. You can see that miliary pattern. Usually miliary disease occurs when the active disease erodes the pulmonary vessels, and hematogenously it is spread all over the body. TB can affect bilateral lungs, and sometimes it can cause even pneumothorax, and you can see that the consolidated lung line, and this is a pneumothorax patch. This is again left upper lobe lesion which has eroded the pulmonary vessels and caused disseminated TB or miliary TB. It can involve the bone, the typical Pott's fracture, and you can see that the vertebral body has been collapsed and destroyed. There is sclerosis, and the disc space is narrowed, and the vertebral margins, they are destroyed, they are blurred. Okay, can chest X-ray confirm the diagnosis of TB? No, because there are other conditions which can look like TB, and there are other granulomatous diseases like fungal infections, sarcoidosis. So this patient has some prominent lymph nodes here and involvement bilaterally, but this is sarcoidosis. So you have to keep in mind other diagnoses before you put the patient on ATT. And this X-ray again, you can see that bilateral hilar adenopathy, and this is typical for sarcoidosis. Specimen collection, sputum for smear and culture. Usually 3 sputum specimens are taken for smear and 1 specimen for culture is enough. Why 3? Because the 3 specimen increases the sensitivity in detecting tuberculosis. What if person is unable to cough up sputum? In that case, we have a couple of options, in fact 3 options. We can induce sputum. Sputum induction means that you give patient bronchodilators, you nebulize the patient with hypertonic normal saline, and then do the chest physiotherapy and stimulate the patient to cough up sputum. And studies have shown that the sputum induction and BL has almost comparable sensitivities. Gastric aspiration, usually in those patients who cannot produce sputum and they swallow, and early morning gastric aspirations can give you positive AFB smears. We don't culture gastric aspirations because sometimes the environmental non-mycobacterial species can contaminate the aspiration. And this is the AFB smear showing acid-fast bacilli in a sputum specimen. This is a medium showing culture of the TB bacillus. In olden days, usually on solid media, which is LJ media, the culture takes so long, 4 to 6 weeks to grow. And by the time patient disease must be advanced, or patient might have responded to ATT. But now there are liquid media or a back-tuck system, which is in Shaukat Khanam and Aga Khan. And in that system, the TB cultures can become positive in 10 to 14 days. So that reduces a significant amount of time. So take home lesson that old method takes more time, but now with new back-tuck system, it can be quicker. Okay, about case definitions. It's very important to define your case. Whether this patient has a pulmonary TB, extrapulmonary TB, and why the case definitions are important, especially if you are using recommendations for regimens. There are standardized regimens for every category, and especially if you are communicating to other physicians or referring, you must be knowing that your patient fits into which category. So is it pulmonary, extrapulmonary? Pulmonary, positive smear, negative smear, and previous history of treatment. New case, or this patient has been treated before and he has a defaulter, it's a relapse, it's a failure, or it's a chronic case. Okay, flow diagram. What if sputum AFB microscopy comes positive or negative. If 3 smears come back positive, then it's simple. This patient has TB, patient will receive treatment. If this patient's only 1 smear is positive, then you have to look at the X-ray, you have to look at the history, physical exam, and other demographic and epidemiological clues. If those suggest that this patient has TB, patient will get the treatment. But if this is negative, then probably patient doesn't have TB, but you will follow this patient closely. And this is again lesson which we read in our medical text. Don't treat the lab, treat the patient. If there are 3 smears negative, then this patient might be having some other infection, so this patient gets other antibiotics, and if this patient improves, this is not TB. If patient doesn't improve, you repeat AFB, and if further smears become positive, this patient gets TB treatment. But otherwise, you will follow this patient as if this is not TB. Basic principles of treatment, you all know. Safe and effective therapy and shortest time. Compliance is an issue. It's very hard to take TB medicines for 6 months, 9 months. We have to use multiple drugs as the organism acquires resistance very quickly, and never add a single drug to a failing regimen, and ensure adherence to therapy. This is very, very important. Every day we see patients who take TB medicines for 1.5 months, 2 months, they feel better, they stop the medication, and now they relapse and come back to you again. So they may now develop MDR, which is a big hazard. What are the essential TB drugs or first-line TB drugs? Isoniazid, rifampin, PZA, streptomycin, ethambutol, and these are the dosages in milligram per kg. Studies have shown that 3 times weekly, if you give ATT 3 times weekly, it has similar efficacy. But this has to be done under DOT, directly observed therapy, because if patient misses a dose, then stakes are high. Okay, let's wake you up and throw at you some questions. 38-year-old shopkeeper comes to you with a complaint of cough, fever for the last 1 month. On further inquiry, you find out that he has taken 4 ATT drugs for 2 months and 4 months ago. So how you are going to proceed with this case? So he was considered tuberculous, though we don't know what was his sputum smear, what was his X-ray, but we assume that he might have TB, and now he has stopped the drugs. Now what would you do? You want to reconfirm. Is this smear still positive? What does his X-ray show? Right? Okay. So what would you do here? What's the best option? A. Sputum smear, culture, and repeat X-ray. Why would you do culture? It can be debated, culture, but this patient has taken ATT, MDR, drug resistance, and in that culture sensitivities are the most important point. So you do the option A. Same scenario, the patient turns out to be active case. His smear positive, his X-ray is showing cavitary lesion. Now how would you treat this case? You would continue with the same 4 drugs. You will replace 2 initial drugs, isoniazid, with second-line drugs, or start 5 drugs including streptomycin. You will add streptomycin, or you won't start ATT until the culture results come back, or start 5 drugs and add ofloxacin. E or C? E could be correct, but according to WHO recommendations, C is the correct answer. Okay, WHO recommendations, this is a photograph of that, and in category 1 you can see that is this patient fit into this category? Is it a new smear positive patient? Probably not. He had that before and he has been treated. Pulmonary TB with extensive parenchymal involvement, concomitant HIV disease, or severe extrapulmonary doesn't fit into this criteria. So if a patient fits into this, then the standard regimen, 2 means 2 months. H is for isoniazid, R is for rifampin, Z is for pyrazinamide, E is for ethambutol. This is initial phase. We treat TB in 2 phases, initial phase and continuation phase. So initial phase, this is 4 drugs, and in continuation phase, we use 2 drugs. H is for isoniazid and R is for rifampin, and 4 denotes 4 months. So the total duration, if a patient fits into this category, is 4 months of treatment. So 2 months of 4 drugs and 2 drugs for 4 months. So our patient doesn't fit into this category. Let's proceed. Same scenario. Patient turns out to be an active case of TB, and you started 5 drugs. As you said, you will add streptomycin. Now, when would you ask the patient to come to you with investigations? Of course, you will follow the patient, making sure he is compliant with the medications, he is not having any side effects. But when will you ask for investigations and chest X-ray? 8 weeks or 2 months. D is the correct answer. So you will ask the patient to come at 2 months with sputum AFB smear and chest X-ray. And you want to make sure that with your ATT, he has become AFB smear negative and he has shown some resolution in his chest X-ray. Okay. 2 months have passed and his sputum smear is negative. Chest X-ray has shown resolution. Now what you are going to do? Stop streptomycin and continue other 4 drugs for 6 months. You will continue rifampin and INH for 6 months. You will stop streptomycin. You will continue 4 drugs for 1 more month and then 3 drugs for 5 months. Or you will continue 3 drugs for 6 months, isoniazid, rifampin and ethambutol. Or continue all 5 drugs for 1 more month and then 3 drugs for next 5 months. B, C. Well, E. So we have a tie here, equal. So this is C is the correct answer. And this is according to the WHO recommendations. And you can see that our patients fit into the second category. He is a defaulter. So if a patient who has defaulter or who has relapsed, or he has previously treated sputum smear positive pulmonary TB, this is the regimen we have to follow. So rightly, 2 months, 5 drugs, you added streptomycin. Now he has come to you after 2 months. So 1 denotes for next 1 month, he's going to get 4 drugs. You will stop streptomycin, and after 1 month, you will continue with the 3 drugs, isoniazid, rifampin and ethambutol to complete 5 months. And again, this is treatment category. You can review it later. You will get the handouts later. In the third category, these are new smear negative pulmonary TB patients, and they have the same regimen as we have for category 1. And for category 4, remember that the patients who are you are suspecting MDR TB, you should refer to specialist. Okay, this is a algorithm showing actions when patient interrupts the treatment. So if you look here, our patient interrupted the treatment for more than 2 months. And you did right, you did the sputum smears and they come back positive. He was category 1 initially when he started the treatment. So if a category 1 patient fit into this and comes to you, you start the regimen for category 2. 5 drugs for 2 months, 4 drugs for 1 month, and then 3 drugs for 5 months. But if this patient had been in category 2 to start with initially, and then after default he comes to you, this is a case where you should refer it directly to a specialist, because here is a high suspicion he might be having multi-drug resistant TB. Okay, these are the definitions. What's the cure? What's the treatment completed? Cure, patient who is sputum smear negative in the first month of treatment, or at least once on the previous occasion. This is a cure. Monitoring patients, very important. Report is very, very important because it's a long haul. Patient must be very compliant and you should be very supportive to the patient. You should explain, educate the patient about all these things. Baseline laboratory testing, these are not recommended routinely. So baseline hepatic measurements hepatic measurements are indicated only for those patients whose initial evaluation suggests they might be having a liver disorder, patients with HIV infection, or pregnant women and those in immediate postpartum period, and patients with a history of chronic liver disease. Patients should be followed up at least monthly. They should make sure that adhere to the treatment regimen and look at the signs and symptoms of active TB. Are they getting better? And for the side effects, especially hepatitis. Okay, these are the common side effects, the minor side effects, and which drugs are the culprit and what to do. Remember to explain to your patients that rifampin turns the urine orange. Otherwise, patients sometimes get very scared that they are having hematuria. Two most important thing is deafness, which can be permanent. So if you start your patient on streptomycin and patient is elderly and you are not following creatinine, streptomycin levels be high enough that they can damage the cochlea permanently. And this patient might present with vertigo, deafness, visual impairment, which is very important with ethambutol. So that's why some people don't use in renal failure, and we don't use in children less than 4 or 5 years of age, as they cannot tell you if they are having red or green vision problems. Adherence is very, very important. Okay, these are the persons which are at high risk of drug resistance. So you should look for these signs and be very suspicious. Extrapulmonary TB. Treatment regimen is same in extrapulmonary TB except in meningitis and miliary TB. Bone and joint TB, miliary TB, and TB meningitis in children you usually treat for minimum of 12 months. Okay, this is a table showing that bone and joint TB you treat longer periods, CNS usually 9 to 12 months, and miliary TB or disseminated TB also, because there is a high risk that this miliary or disseminated TB has involved the CNS. In that case, the treatment should be prolonged. When should we use steroids? Steroids are very commonly used. Some physicians, when the patient comes to them, they initially first start steroids, and after 2-3 days they start ATT. They say that the patient feels better. But steroid has side effects, and what if the patient has drug-resistant TB and you put the patient on steroids and the resistant TB will flare up? So that's very, very risky. So the recommendations are only under two conditions. Either patient is having pericarditis to prevent the constrictive pericarditis, and CNS tuberculosis to decrease the adhesions and cranial nerve involvement. We don't give steroids for source sepsis. No. Only meningitis and pericardial effusion. Time period 6 months. Okay, there are special situations you should be aware of. Pregnancy, breastfeeding, conception, liver disorders, chronic liver disease, acute hepatitis, renal failure, HIV infection, immuno-compromised patients, multi-drug resistant TB, and they have special regimens depending on which condition the patient fits in. But as far as primary care is concerned, you would be dealing more with the pregnancy, breastfeeding, contraception type thing, and also some stable patients who are having chronic hepatitis C, who are not having liver disease, they are just hepatitis C or B positive. And the other thing I wanted to point out that in pregnancy, many people think that ATT has a teratogenic effect. So WHO recommendations are isoniazid, rifampin, PZA, ethambutol. You can use safely in pregnancy. In USA, they don't use pyrazinamide. They say that the data is insufficient to say that it doesn't have a teratogenic effect. You cannot use streptomycin in pregnancy. So these initial first 4-line drugs you can use in pregnancy. They are safe to use in breastfeeding also. And acute hepatitis, we have a special regimen, and I would probably suggest that you should refer it to a specialist. In renal failure, we have to adjust doses for a couple of drugs, and HIV immunocompromised, they are more specialized sections. Okay. A 32-year-old healthy woman comes to you with complaint of non-tender posterior cervical lymphadenopathy. And history and exam revealed no other finding except that her father 10 years ago had been treated for pulmonary TB. She is not taking any medications except her contraceptive pills, and she lives in a small house with her husband and 9 children. Now, what's the next step you are going to do? Biopsy. You did a biopsy, it come back granulomatous inflammation, and on smear AFB bacilli are seen. What you are going to do now? Which regimen you are going to put her on? 5 drugs. If you remember the WHO protocol, new cases extrapulmonary, you can start 4 drugs. So which 4 drugs you are going to start? Isoniazid, rifampin, EZA, ethambutol. Okay. Her cervical lymphadenopathy settles, but after 8 months she comes to you very angry. The doctor, you put me on medications, I was using contraception, and my other doctor said that the other doctor put you on rifampin, and that's why your contraception was not effective. I already have 9 children, so I am having this 10th child. So the point, take-home message is that these drugs have interactions. So especially rifampin interferes with the action of estrogen. So any patients who are taking contraception, those patients should be using second mode of contraception also. And this is for your reference, that there are these medications which can interfere, but this is commonly seen, that's why I put the case here. Okay, you should be treating more patients. Your role is very important because the complicated cases are less, but the take-home lesson again is that for the serious cases, you should refer to the specialist. Infectiousness, it's a very contagious disease, so you can only say that this patient is non-infectious if they are on adequate therapy, have a significant clinical response to therapy, and have had 3 consecutive negative sputum smear results. Prescription writing is very, very important. You have to go with milligrams per kg, and sometimes what happens that you put the patient on ATT, patient gains weight, and then the patient becomes underdosed. So you have to follow the patient and adjust the ATT according to the weight. Okay, you have to educate your patient about the TB, and the take-home message is learn how to treat tuberculosis in primary care setting, get yourself aware of the WHO protocols, follow the standard treatment regimens. And one patient was referred to me who was taking ATT, 4 drugs, 2 drugs in the morning, Myrin P4, 2 tablets in the morning and 2 tablets in the evening. So that split dosage doesn't give that peak to kill the bacteria, and the antibiotic levels might be subnormal, and this patient might develop resistance. So follow the standard regimens and refer the severe and complicated cases to the specialist, and you can make the difference and work for the healthier and safer population.